all guests, especially Dr. Basharat Ahmed Kant, neurosurgeon, Dr. Hilal Ahmed Ganai, interventional neurologist, and Dr. Muhammad Yaqub, interventional neuroradiologist. Our Deputy CMO, Madam Fatima Bano, Medical Superintendent Sir, Dr. Abbas, consultants, BMOs, medical officers, President Bakaria, Dr. Ahmed Ali, executive members, Assalamu alaikum. I, Dr. Nasreen Fatima, Vice President, Bakaria Healthcare and Research Center, welcome you all on this beautiful evening at TFC for bidding a farewell as well as to continue this medical education CME as Bakaria always does. This is the end to the 2 days hectic OPD and also a beginning to introduction to the decoding of stroke and interventions in brain hemorrhage. So we'll be, our guests will be introducing us with all these topics. I welcome you all, sir. I request President Bakaria Healthcare and Research Center, Dr. Ahmed Ali, for introducing this program. Please, sir.
Bismillahirrahmanirrahim. Distinguished guests from really HIPAA Neuroscience Group, led by Dr. Basharat, neurosurgeon, Dr. Hilal, interventional neurologist, Dr. Yaqub, interventional radio neurologist, my dear colleagues, Deputy CMO, Medical Superintendent, District Hospital Kargil, medical officers from peripheries, medical officers from District Hospital Kargil, block medical officers, and my executive body and members. आप सबको इस छोटे से ओकेजन के लिए मैं वेलकम करता हूँ। एक इनिशिएटिव हमने बहुत पहले शुरू किया था, कंटिन्यूइंग मेडिकल एजुकेशन। द रीज़न वाज हम जो मेडिकल फ्रेटर्निटी यहाँ पे सर्विस देते हैं सच ए रिमोट एरिया सर, तो बिल्कुल रिसेंट जो एडवांसेस हैं उससे हम बहुत दूर रहते थे, क्योंकि स्पेशली ड्यूरिंग विंटर सीजन्स। तो हमने यही एक हमारे उसमें रखा था कि हम एक मेडिकल एजुकेशन पे, एडवांस मेडिकल एजुकेशन पे खासकर, और रिसेंट अपडेट्स पे हम टाइम एंड अगेन हम CMEs कंडक्ट करेंगे। तो लास्ट ईयर हमने आपको कुछ आप लोग उसमें पार्टिसिपेंट्स रहे हैं। लास्ट ईयर हमने स्ट्रोक पे एक अच्छा सा एक CME हमने आपने प्रेजेंटेशन किया था, एंड दैट वाज ए ब्यूटीफुल इवनिंग ऑल्सो। उसमें अच्छा खासा क्वेश्चन नंबर भी रहा था। तो इस साल भी हमने सोचा कि आपकी जाते जाते एक्सपीरियंस शेयर करें, हमारे डॉक्टर्स यहाँ पे पार्टिसिपेट करें और आपसे 1-to-1 इंटरेक्शन भी हो जाए और आप अपना एक्सपीरियंस हमें शेयर करें, ताकि क्योंकि फील्ड में और लैक ऑफ रिसोर्सेज और जो मॉडर्न जो डायग्नोस्टिक टूल्स हैं, खासकर MRI हमारे पास यहाँ अभी तक नहीं है। वी डोंट हैव इवन EEG यहाँ पे नहीं है, तो NCV भी हमारे डिस्ट्रिक्ट हॉस्पिटल पे नहीं चल रहा है। तो कुछ चीज़ें ऐसे होते हैं जिसमें मैनेजमेंट का प्रॉब्लम आ जाते हैं। से फॉर एग्जांपल इफ ए पेशेंट ऑफ स्ट्रोक रिपोर्ट्स टू कैजुअलिटी, उस वक्त फर्स्ट इंस्टेंट पे उसको क्या करना है, तो उन चीज़ों पे आप अगर स्पाइनल इंजरी होते हैं उन पे अगर आप हमारे डॉक्टर्स के साथ अगर इंटरेक्ट करेंगे, मैं खासकर डॉक्टर हिलाल सर और डॉक्टर बशारत सर से यही रिक्वेस्ट करूँगा कि आप अपना जो हाईटेक जो एडवांसमेंट जो आपका जो टेक्निक है उससे पहले अगर बेसिक पे अगर थोड़ा बात करें तो वो अच्छा रहेगा। बट यस, एडवांसमेंट भी चाहिए और हमें अपडेट भी आपका चाहिए। जो आप लोगों ने जो खासकर जो माइक्रो इन्वेजिव डॉक्टर बशारत का जो टेक्निक है, वो डॉक्टर हिलाल और डॉक्टर याकूब सर का जो अलग से जो स्टाइल है डील करने का पेशेंट का, वो भी शेयर हो जाएंगे और अपडेट हो जाएगा। बट जो पहले जो एज ए फर्स्ट एड जो ट्रायल जो करना है, उस पर अगर आप थोड़ा सा बात करें तो और भी हाईलाइट हो जाएंगे हमारे ऑडियंस के लिए। तो उसके बाद तो फिर क्वेश्चन, आई होप कि यहाँ पे आपके साथ क्वेश्चन और होंगे और उस पर क्वेश्चन का आपको शायद आई होप कि बुछाड़ हो जाएंगे। और मैं यही उम्मीद रखता हूँ कि इस इवनिंग को आप लोग एकेडमिक के लिए आप इंजॉय करेंगे और फिर लास्ट में थोड़ा सा भोजन भी होगा तो उस भी आई होप कि आप इंजॉय करेंगे। बट हमारा मेन मुद्दा होना चाहिए कि लर्निंग का, मेरा यही रिक्वेस्ट है। और इंशाल्लाह आगे भी हमारा यही बिकॉज मेडिकल साइंस इज सच ए ब्रांच कि आपको पलक झपकते ही इसमें एडवांसमेंट आ जाते हैं। तो आगे भी इंशाल्लाह आपके साथ हम कोऑर्डिनेट करके ऐसे CMEs और सेमिनार्स हम कोशिश करेंगे कंडक्ट किया जाए। तो वंस अगेन मैं आप लोगों का यहाँ पे वेलकम करता हूँ। और कैंप के बारे में बताऊँ तो आप लोगों का बड़ा हेक्टिक शेड्यूल रहा है। OPD के हिसाब से मोर देन 460 पेशेंट्स OPD आपने देखे हैं। और आई थिंक EG भी हमारे अदनान भाई ने बहुत ज़्यादा किया है। तो मोर देन, आई डोंट नो द फिगर एग्जैक्टली, 15 एंड विच इंक्लूड्स वन EG इन डिस्ट्रिक्ट हॉस्पिटल करगिल जो SNCU में किया, एक एसिफिक्सिएटेड बच्चे का जिसको हाइपोक्सिक इस्केमिक इनकेफेलोपैथी हुआ था। उसमें फिर हमारे डॉक्टर हिलाल साहब भी वहाँ गए थे और हमारा पीडियाट्रिशियन से इनका उनके साथ डिस्कशन भी हुआ था, केस डिस्कशन भी हुआ था। और उसके बाद डॉक्टर बशारत साहब ने 2 दिन के जो OT जो कंडक्ट किए वहाँ पर न्यूरोसर्जरी स्पाइन के 4 केसेस किए हैं। मैं आपका बहुत ही आभारी हूँ सर। और ऊपर से डॉक्टर याकूब सर ने अल्ट्रासाउंड भी किए हैं वहाँ पे, डायग्नोस्टिक सेंटर पे इकोज भी किए हैं और कुछ प्रोसीजर्स भी आपने डिस्ट्रिक्ट हॉस्पिटल पे किए हैं। एक CT गाइडेड आपने रूट ब्लॉक दे दिए हैं और भी कुछ CTs किए हैं। तो थैंक यू वेरी मच। ये जो चीज़ें हैं हमें सीखने का था, वो आपका जो प्रोसीजर था सर, मैं तो चाहता था कि वो प्रोसीजर हम देख लें, बट अनफॉर्चुनेटली मैं डॉक्टर बशारत के साथ थिएटर में रहा था, आई कुड नॉट वॉच योर प्रोसीजर। तो आई होप कि आप लोग एंजॉय करेंगे इस इवनिंग को। थोड़ा सा प्रोग्राम स्टार्ट करने में देरी हुआ क्योंकि शायद हमें पंक्चुअलिटी का थोड़ा सा भूल गए हैं सर। रिसेंटली जो कन्फ्लिक्ट हुआ इंडो पाक का, शायद उसको वो रीज़न तो आई विश आइंदा जब हम ऐसे प्रोग्राम करेंगे तो वी आर डॉक्टर्स, तो थोड़ा सा टाइम का हमें ख्याल तो रखना पड़ेगा। बट मजबूरी होते हैं, किसी का कॉल होता है, किसी को इमरजेंसी होता है, तो ये तो पार्ट ऑफ लाइफ है। बट वंस अगेन आई थैंक यू ऑल। आप लोग आए, तशरीफ़ लाए, अपना टाइम आप निकाल के आए हैं, उस प्रीशियस टाइम को निकाल के यहाँ पे आप शमूलियत कर रहे हैं, इसके लिए मैं बहुत ही आप लोगों का आभारी हूँ। थैंक यू वेरी मच।
क्योंकि हम पेरिफेरी में जब काम करते हैं, आई बीइंग ट्रेन्ड एज अ गायनोकोलॉजिस्ट, कोई कार्डियक पेशेंट आ जाता है या कोई स्ट्रोक आता है, हम बिल्कुल हेल्पलेस हो जाते हैं। आई यूज्ड टू कॉल सो मेनी सीनियर्स। विलायत सर को मैंने कई बार कॉल किया है ECG दिखाने के लिए, या कोई भी प्रॉब्लम हो तो हम इसी तरह से मैनेज करते हैं पेरिफेरी में। बट फर्स्ट लाइन मैनेजमेंट प्लीज़ सर हमें थोड़ा सा ब्रीफिंग दें।
In neurology, I was not knowing whether to go or not in this branch and how beautiful this branch is. Once I joined it 6 months later, I realized this is the best branch for me, at least, because the neurology is the only clinical branch where you do not need any investigation to diagnose. If you know things, you can diagnose anything. And neurology is very vast branch, right from toe to top. It includes movement disorders, which is totally a clinical branch. Like a cervical dystonia, you go Botox, patient improves completely. Today I have seen 2 patients, facial spasm and blepharospasm. You give Botox, they improve 100%. Just 50 units of Botox. Epilepsy is another branch, very advanced branch, epilepsy in neurology. We need video EEGs, and then clinical history to diagnose and treat. Right from pediatric to 90 years of age, epilepsy is present in different ways: focal, generalized, myoclonic, absence. If you diagnose epilepsy properly and treat it, it is usually patients are well controlled. We treat epilepsy patients, and 90% patients of ours are controlled, depending upon the drugs which we use. I have seen recently a child came to us. She was following Dr. Padma Madam from AIMS. They were from Kashmir, and they were following her. She had come to the Paras. A child had she was around 6 years old. He had an epileptic encephalopathy. And even Padma Madam got that. She was like, I have to go back. How can I keep patient here? You please manage the patient. So just permutation and combination of these drugs, which we have 10 to 12 drugs of anti-epileptics. Within 5 days, patients, on day 1, we had done around 5 or 6 EEGs in 2 weeks. On first day, EEG was so much abnormal, ma'am was worried. She is a Padma Shri in India. And then after 4 or 5 days, everything happened. EEG became normal in a child. So it was a primary idiopathic absence epilepsy. So to treat an absence epilepsy, you should know what are the drugs which are required for an absence. Sometimes there is a resistant absence epilepsy. You have to give sodium valproate, ethosuximide, and lamotrigine. If you know what drugs, where we have to use. Sometimes focal epilepsies, resistant focal epilepsies. You have to treat drugs properly, know what are the drugs which help in focal epilepsy. People improve. And then generalized epilepsy. There are many drugs which precipitate some seizures, like myoclonic absence seizures are precipitated by carbamazepine and oxcarbazepine. So, knowing the side effects of the drugs and proper benefit of the drugs, epilepsy is near total completely controlled. We cannot say it is totally cured, because the definition says if a patient has an epilepsy, he should be at least 5 years seizure free without drugs, then we can tell patient is cured.
2 years.
5 years.
Previously, now it is 5 years. Some people say, because they are saying, and definition of epilepsy is if a patient has one seizure with tendency of 40% of another seizure, that's an epilepsy. Not 2. Earlier they were saying 2 or more seizures is an epilepsy.
Age is in criteria.
No, epilepsy and yes, in pediatric age group, usually people respond to when drugs get controlled in pediatric age group, just like a febrile epilepsy seizure. We even do not call it epilepsy. Febrile seizures, they are just for 5 years, they do not happen after that. And then there are some epilepsies in early childhood which get controlled. But hardcore epilepsies, which are syndromic diagnosis, do not, they need drugs predominantly. Just like in a 8-year boy or female comes to us with juvenile myoclonic epilepsy, she or he has to take drugs lifelong. Similarly, absence epilepsies get controlled, improve after 5-6 years. Or then other types of epilepsies like middle temporal lobe epilepsy. Surgery is a good choice, but people have to take drugs otherwise. Then epileptic encephalopathies, Dravet syndrome, Bruce syndrome, and other things, you have to manage patients very well. Focal epilepsy is structural, there are structural changes in the brain, and then focal epilepsies, yes, 1 or 2 drugs are required. Problem with management of epilepsy with the doctors is, I am feeling even neurologists are not giving proper adequate dose of the drugs which is required. Now I am partially a surgeon, not a full surgeon like Bashar Saab. But what I feel, many among you are surgeons. Surgeons have hands and surgeons can do wonders. A physician or a clinician has to use these drugs properly up to the maximum dose. Giving a drug by a physician who is giving these drugs for years together, just like a methylprednisolone 1 gram, what will happen? We have given 2 gram, 3 gram in a day. So why should we, as a physician, should worry of giving a methylprednisolone? Nothing will happen, even if sugars will be high. So what is the problem? So my understanding about the physicians is people are unnecessarily scared of giving the drugs. That is the basic. Even give antihypertensive drugs. We can give in management of hypertensive crisis 4 or 5 drugs. What will happen? So nothing will happen. So same is the management of epilepsy. If you know what are the drugs, what is the dose of the drugs, give the maximum dose of the drugs. body weight, just like oxcarbazepine has 20 milligram per kg body weight. In a patient of 90 year, you have to give 1800 milligram. That means you have to give at least 900 BD. Drug comes with 600 mg, so you have to give one and a half tablet of oxcarbazepine in 90 kg weight. So applying drugs properly is the first thing where we as a physicians lack, even neurologists I would say. Similarly, like Parkinson, yesterday a patient came, he had been properly diagnosed as a Parkinson by here a physician, very good given drugs, but that very half dose Syndopa, it is not a dose. Maximum dose of Syndopa for denying a patient is 800 milligrams. Telling a patient does not have Parkinson, even if you can give 800 milligrams Syndopa to a normal person, nothing will happen. So if you are suspecting a Parkinsonian patient, give an adequate dose of around at least 300 one tablet TDS, or suppose there is, I have seen one patient in my life where giving one tablet in a patient causes dyskinesia. Otherwise 2 tablets thrice a day does not cause dyskinesia. So it is okay if somebody is worrying for 3-4 days half tablet TDS, but finally you have to give a dose properly which is required. So drugs are very required. Similarly, demyelinating disease, MS and other diseases are very common, and again steroids and immunomodulated drugs are the treatment of choice. Yes, in MS, multiple sclerosis, it has been very now commonly seen among the earlier they were saying it's not treatable. Now it is near total treatable. You have to give drugs appropriately, and MRI is the backstone of treating the MS patients. Similarly, other demyelinating disease, optic neuritis and other things, steroids are the drug of choice. You can give it here only, just knowing RAPD. Somebody should know RAPD, visual impairment. They can give steroids in for 3 days, there will be no complication, then send a patient for MRI. So worrying at diagnosis, if you are sure there is a diagnosis, then better is to give a drug than sending a patient to some higher center. And luckily you are getting an MRI, that is the best possible thing you will get. Before that, if you have an MRI, and you can diagnose many things here. Neurologically, there are other diseases also. So my gut feeling is always in, not only here, it is a far off place, even in government medical colleges and other places, people worry unnecessarily. If I am comparing myself in treating an aneurysm, which is a ruptured and there is a blood on it, and then treating any neurological disease, I will never sleep if I have to treat that day. I am thinking what I will do when I have to treat an aneurysm endovascularly. But I have never even thought of giving methylpro, whatever drugs, anti-epileptics, 4, 5, 6. I have never been worried. Any drug I have never worried. But once an aneurysm patient comes to me, I will take only if I am available. I will make sure I am available 24/7. If I will take an aneurysm patient, that is a very dreaded disease to treat. It can rupture, re-rupture, patient will die there. So comparing diseases, different diseases, why a physician should be unnecessary worrying about giving drugs. I don't feel giving even antihypertensive does not cause significant impairment. Yes, there are some problems in understanding the disease. Recently we had a patient of SH. Patient was clipped. Why I am giving you, I will just making you to understand how things go. Patient had been clipped. Post clipping, patient developed 4 times strokes in a duration of, same side strokes, in a duration of 1 month. So if same, and she is improving also. After every 2 days, patient is improving, she is going home, she is coming back, and on discharge, she is getting one antihypertensive drug, 1 nimodipine, and patient is being told to walk. Because there is impairment in the weakness, so she will improve. So once she is taking this antihypertensive drug, nimodipine, and then she starts standing and she is getting everyday stroke. So what was the mechanism was, once they had done clipping, there was MC was occluded. So she had collaterals from HCA to other side. So once she was taking antihypertensive on that nimodipine, which decreases BP, then she was standing, she was developing hemodynamic infarcts. Just stopping antihypertensive drug with nimodipine was sufficient enough to treat the patient. So what is the hemodynamic, but only this thing. So in an elderly patient, why we worry in giving antihypertensive only thing, because we do not know what is the intracranial circulation, how much stenosis there is, how much amount of blood decrease in blood pressure will impair the blood circulation. That is the only reason. In young adults, there is no problem. They can maintain anywhere from MAP of 80 to MAP of 180. You can manage them patients in around 40, 50, 60 years. So I was discussing about the neurology. Only difficult portion of neurology is dementia, neurodegenerative diseases, which still in the world does not have any treatment. But if a patient sits in front of a neurologist who is trained neurologist, he can just in 3 words tell you a patient has a Alzheimer's disease, frontotemporal dementia, DLB, dementia with Lewy body disease, vascular dementia, or whatever is the dementia. We do not even require, we first diagnose, then we see in the imaging what is the type of dementia patient have. And every dementia behaves differently. So in FTD, patients are so much aggressive or so much aggressive. Sometimes they open their clothes on the roads, and they do not know who they are. But their memory is clear. They will never, they will reach the home. So in on other side, Alzheimer's, they do not know who they are. They even lost the insight who they are, and even do not know who they have been married to, and do not know where they live. Every insight has been lost in ADs in the later stages. Earlier stage they have. Finally, there are many. Neurology is such a wonderful branch which I am presently just a patient is coming on the road seeing. Just on looking on eyes of a person, you can diagnose if a patient has mitochondrial disease like central progressive external ophthalmoplegia, or is that ptosis because of myasthenia, or is this a ptosis something else because of health. So this only clinical sinus, such a beautiful clinical sinus is a neurology, where then you become so confident, you even can tell those people who are normal, you tell them your disease and you can diagnose them so early. They do not know, but doctor knows what is the disease. Attendants even years together do not know they have some disease or they have some syndrome. Finally, I am a neurologist, stroke neurologist, changed my branch from good clinician to an intervention neurologist. It happened luckily. I started my journey in 2017, did my fellowship in Gurgaon, Artemis, 2 years, full hard going close after my DM. I done DM from Kolkata for 3 years. So the teachers were very good. Difference in Kashmir and our setup, Northern India teaching and their teaching was totally different. And their criteria, I was taught by so beautiful people. They were telling me once you will go to Kashmir, there should be a difference among the neurologists. You should tell them I am a neurologist trained by Kolkata people. So I am very lucky. My teacher was Professor Shamal Kumar Das. He had that fellowship in Movement Disorder from Calgary in '84. Once I was not knowing those days, once I joined tick disorder. It is so common, embedded in the society, tick disorder. You have to just a Revocon tablet, tetrabenzene, patient improve. But you have to diagnose these ticks. It is sometimes embarrassing for the child or a person who has a tick. Just closing multiple or moving unnecessary these sometimes. But once you know it is tick, you give one tablet, it improves. And many people diagnose these ticks as epilepsy. I've seen many. So this clinical sinus, if a patient has a backup of clinical sinus, then you can do wonders anywhere. So I am directly going to stroke, because why? Stroke is a branch where patient, if you treat patient properly at proper time, there are so good results. There are such a wonderful results. And it is life-saving procedures. We are lagging in Srinagar also. What world is going, they are far ahead of us. So I will go stroke because I have been told to be in the. So we will just start from right-sided damage will cause problem in the left side. We all know there is crossing of the pyramidal tracts. So, and left side any problem will cause problems on the right side in the pyramidal tract. Only cerebellar, if there is some damage in the cerebellum or its pathway, it is ipsilateral because there is double crossing of fibers. So cerebellar, anything happens, it's ipsilateral ataxia, ipsilateral anything, cerebellar and system. We always talk in brain part of a brain and its connections. Once we were told, we were being trained, they were never letting us to go out of history And once I was in MD, people were telling history से सब कुछ निकलता है, but I was not understanding यार ये history कैसे निकालते हैं ये लोग. Then once I went to Kolkata, and finally I realized if you know history taking properly, if you then analyze history to the structure part of a brain, just like I will tell you, a patient is having abnormal movements. So system of movement disorder is in the basal ganglion and its connections. So problem is somebody has a movement disorder, it is in the basal ganglion and its connection. It will be never in the cortex, motor cortex. If a patient has an ataxia, abnormality in ataxia or dysmetria, it is problem is in the cerebellum system or it is connections anywhere. So this is you should know first which problem lies in which structure. Then you can analyze things easily. So definition of stroke is sudden onset, any neurological deficit anywhere, which is because of vascular origin, is a stroke. And importance is early recognition of symptoms. Again, we have seen many patients who have strokes, but either they have been labeled unfortunately because symptoms are not being recognized early, or sometimes other symptoms, like today I have seen a patient, there was written acute stroke, but patient had weakness because of Parkinsonism. So people sometimes miss Parkinsonism as strokes. So Parkinsonism will have a rigidity with tremor, and stroke patient, if post-stroke patient will never have a tremor, they will have only spasticity, they will never have a tremor. Because tract is different, corticospinal tract causes spasticity, and then if patient has a Parkinsonism, it will cause rigidity with tremor. So predominantly, any patient who is walking, who has a balance control, balance is the most important advanced thing in which God has given to the humans. Any imbalance in any part, which is unilateral imbalance, is a stroke. And if imbalance is associated with subtle speech impairment or dysarthria or whatever it is stroke unless proved otherwise. Because it is unilateral, stroke usually has a unilateral presentation. So eyes we miss most of the time. A stroke in the eyes are missed, whether it is central retinal artery stroke or whether it is a posterior circulation stroke. Because posterior circulation stroke, patients do not know they have problem in both eyes. They say we have problem in, if patient has a left homonymous hemianopia, they say left side se problem hai. They go to ophthalmologists, and we are so busy clinicians, we never do confrontation in them. That is the problem with ophthalmologists also, neurologists also, and physicians also. Otherwise confrontation just for 2 minutes is very strong indicator. You can check homonymous hemianopia very easily, and it is very small, 2 steps in homonymous confrontation method. I have diagnosed many patients of posterior circulation stroke just on confrontation. You first do not require anything, neither CT, nothing. If patient comes to you, he has a visual impairment, एक आंख बंद करेंगे, दोनों से confrontation करेंगे, और दूसरी एक आई में भी एक ही side का, if patient is in the right posture, so left sided him, there will be hemisphere of one this whole visual area which we call perimetry. One side will be lost, and on another side, same side will be lost in another other eye. That is a posterior circulation stroke, and right homonymous, left homonymous hemianopia, right PCA tertiary infarct. You never need anything more. When you do stroke, there is the PCA tertiary infarct. So then arm weakness and leg weakness, this is the common thing which we diagnose usually stroke. Sudden onset weakness in arm, only this thing we recognize. That is the problem. किसी का हाथ का वीकनेस होगा, वी से सब बाकी चीजें स्ट्रोक नहीं, हाथ का वीकनेस स्ट्रोक है. When visual loss is a stroke, slurring of speech is a stroke, complete speech loss is a stroke, imbalance is a stroke, and speech में there can be an aphasia. Sometimes aphasia is missed, this sensory aphasia. People say अचानक से उसको भूल गया. I've seen many people. Patient has a sensory aphasia. Sensory aphasia means मैं बात कर रहा हूँ, दूसरा बंदा बात नहीं समझ रहा है. It is a language disorder. मेरी बात वो समझ नहीं, sensory area पे जो language का area है वो उनका मतलब stroke होगा उस area पे. He will not be able to understand. But this does not mean he does not have a memory impairment. उसका memory impairment कुछ भी नहीं है. And they are just suddenly, if a patient is not able to understand our language, it's a speech disorder. It is not a memory disorder. मेमोरी, जस्ट हाउ टू कन्फर्म इट, आप अपना हाथ उठाइए, उसको बोले ऐसे, जस्ट इशारे से बोले, वो हाथ उठाएगा. सो ही इज एबल टू अंडरस्टैंड योर अदर वेज ऑफ कम्युनिकेशन, बट लैंग्वेज उसको आपकी समझ नहीं आ रही है. दैट इज कॉल्ड सेंसरी एफेजिया और वर्निकीज एफेजिया. फॉर स्ट्रोक एवरी मिनट इज वेरी इंपॉर्टेंट. तो जितना जल्दी स्ट्रोक पता चल जाएगा उतना फ़ायदा है. प्रिवेलेंस ऑफ स्ट्रोक इन इंडिया, it is very high in rural segment. It is 84 to 262 per lakh persons, and in urban it is 334 to 424 per lakh. We know what is stroke. It's called sometimes CVA. There are two types of strokes: ischemic stroke and hemorrhagic stroke. So I will go first in the ischemic brain strokes. Ischemic retinal stroke. I have seen last 1 month 3 patients referred late. They had complete ICU occlusion with vision loss in one eye. They were in ophthalmology department admitted, and finally once they 4-5 days they come to us and we see their ICUs occluded and ophthalmic arteries occluded and central retinal arteries occluded. So vision loss is a stroke unless proved otherwise. Then spinal strokes are usually missed, and it is very rare entity, anterior spinal artery infarction, but these are predominantly missed by neurologists, by everyone. Yes, presentation is sudden onset, paraplegia with urinary incontinence with intact posterior column is a spinal stroke. If a patient comes, suppose this is the periphery, patient comes with this is right side, this is left side. So right side weakness with aphasia, and there is this sign, which there is a clot in the MCA, dense MCA sign. You can see it is an emergency, you have to thrombolize the patient. You cannot wait for radiologist who is not available sometimes, or you will send, the clot in a middle cerebral artery is dense MCA sign, you have to thrombolize, and this is a large artery occlusion, you have to send the patient for endovascular intervention. If every minute which delays will not allow in the future patient to improve. So this patient after 24 hours will develop this type of problem, which was, there was nothing in the stroke. CT in first 6 to 12 hours, even 24 hours does not pick ischemic strokes. Normal CT does not mean patient has a stroke. This is another big problem which patients get very satisfied. Once we tell them CT normal है, बड़ा सा stroke होता है, they get satisfied, कुछ भी नहीं है. We have to tell them this is the bigger problem than brain hemorrhage, क्योंकि brain hemorrhage के results अच्छे हैं if it's a small hemorrhage. Recovery is good. Ischemic stroke, that whole territory gets bloodless and its results are very bad. In a small lacunar infarction, we were discussing today, we have seen 2-3 patients in an internal capsule, small lacuna of 0.5 mm will never allow a patient to improve even after 3 or 4 years in an internal capsule, posterior. So ischemic strokes are more debilitating than hemorrhagic strokes, and this happens after 24 hours if an ischemic stroke is there and you have not picked up early, or you are just kuch bhi nahi hai, CT normal hai. So this is again a CT scan which looks normal. If you change the window of a CT, this is done by the radiologist, you can tell them change the CT. There is some hypodensity happening. After this, you can see here, if you compare this side of the brain with this side, you can see there are this gyration, and here in gyrations of this gyruses, they are impaired. And then this happens after 4 to 5 hours in the CT, and this finally, this is the stroke. So CT scan normal, and just not looking closely to the images, even by the radiologist, can miss a patient. You can thrombolize it very early. Drugs are very freely available. Again, problem with us is just worrying about giving thrombolysis. Now people have extended thrombolysis period from 4.5 hours. People are saying we can do 9 hours, 10 hours thrombolysis. If patient comes to you with a normal CT, with an hemiplegia, even if it is functional, you can thrombolize. Nowhere in the world you will be labeled anywhere by the court. So giving thrombolysis is far better. You have to just take a consent, and drug is freely available everywhere. You are doing it, and do not get afraid of giving these thrombolysis. There are very less chances of hemorrhage. Yes, hemorrhage happens if a patient delays after 4.5 hours, 5 hours, and there is a large artery occlusion. If you give it within 1 hour, nothing happens. Usually doesn't happen anything.
From the perfusion, sometimes it mimics a hemorrhage.
Yes.
These are the problems.
So various types of strokes. This is an MRI slide. This is an M1 occlusion. Totally MCA is occluded M1. There will be, this is the right side, left side there will be hemiplegia. This is superior branch of M2 is being occluded. Again, this is a fasciobrachial area. There will be fasciobrachial weakness on left side. If inferior branch is occluded, again, in this on right side, usually patient will have alexia with agraphia, usually this area. Then artery of Purkinje, I have seen many patients, they directly come with a coma. This is a perforator branch from the basilar artery, which supplies the small area bilateral thalamus. Thalamus is known for consciousness, and if bilateral thalamus gets occluded, partially blocked or infarct, patient come directly with the coma, but the pupils are reactive. Then superior cerebral artery strokes usually have ataxia with other cerebral features. And then basilar artery perforator usually have ataxia with gaze impairment or 1.5 syndrome. Again, anterior spinal artery infarct usually causes spinal artery infarction anteriorly. Picotary infarct usually have 8th, 9th nerve involvement, 10th nerve involvement, usually facial, sometimes 5th, and then they have ataxia. They do not have weakness, they have ataxia. And then this IKA usually have hearing impairment with some imbalance. PCA territory infarct is again visual impairment with some type of ataxia. Anterior choroidal artery infarction usually presents with contralateral weakness because of internal capsule involvement. Lenticulostriatal branch causes weakness, and then ICA occlusion completely contralaterally. They will have within 1 hour they will have gaze impairment and then semiplegia, and then speech gets occluded and they will be led to partial drowsiness in the initial, and within 5 to 10 hours they will be landing to coma because there will be a fast midline shift. Artery of ACA infarcts, PC and ACA usually get missed. ACA infarcts have weakness in the leg with some urinary incontinence, with some subtle drowsiness, and posterior circulation usually have visual impairment. These infarcts usually get missed, and people say they are functional and other things. So managing ischemic stroke is a race against time. The more time we lost, the more problems happen to the patient. Estimated pace of neuronal circuitry loss per minute is typical large artery supratentorial acute infarction. Neurons lost, 19 lakh neurons are lost in 1 minute. Synapse is lost in 1400 Carr's myelinated fibers. Even age is accelerated by 3 weeks just in 1 minute. So this is the devastation which a stroke causes in a large artery occlusion. There is a 15 this item NIHS scale. Usually scales up to 41. This has been multiple times discussed. This is on the internet also. You can just download it and you can fill the form easily. Severe stroke is up to 25, 16 to 25 we call severe stroke. Moderate is up to 15. Minor is up to 4 minor symptoms. But there is nothing like minor or major, because stroke sometimes presents just a small and then second event occurs in the same day because there is small embolus and then artery gets occluded. So unless we say, just like cardiologists, they do angiography to everything, we nowadays never let a patient only on, last year we had on CT angios here, and now you are doing routinely CT angios. Even I have seen CT angios in brain hemorrhage. I got very happy when there is not requirement of basal ganglionic hemorrhage because it's a hypertensive hemorrhage. But still, if you are doing CT angios in a brain hemorrhage or ischemic, it is better than not doing it. What CT angio gives you clear information: where arteries occluded, how much is the thrombus, how much is the thrombus burden, what you have to do, you have to analyze. I have seen many patients. So sometimes there are atypical brain hemorrhages. CT angio can guide you very early, and your hospital is capable enough. There is a good machine, and we have seen many CT angios. Just there is some still training of these technicians required. I was telling to Dr. Yakub also, because once they do CT angio, they had to take films of brain separately and neck separately. They are giving one film in which neck films are dominantly and brain vessels are less. This is happening in Srinagar also, most of the places. So 4 hours and 30 minutes is the gold standard time. This you can do here in Kargil with CT scan. You can do it normal CT scan, whatever is the patient comes with, you think it is a stroke, don't worry, don't tell anyone. You thrombolize the patient. Yes, there are some things where we worry with hemorrhagic transformation. Usually in the elderly, more than 70, 80, there are some small microbilids, we say, they have high risk of bleeding after thrombolysis. But less than 70 or less than 60, you do not even think, you should not think about thrombolizing, worrying about the thrombolysis. You have to take a consent and do the thrombolysis. So last year also I presented a revascularization always is better for the patient. This is a core and this is a penumbra. If you patient has this established infarct, and this much you can save if you do thrombolysis early. I will tell you 1 hour after the onset of stroke symptoms, this was an infarct, this is a perfusion defect. After, if the brain has recovers after clot has been dissolved, everything improves. So less than 90 minutes, if you thrombolize a patient, number to treat is 4 or 5 out of 1 out of 4 or 5. So the early you will thrombolize, it helps in patients. If you thrombolize within 90 to 30 minutes, 3 hours, number to treat is 9. If you thrombolize more than 3 hours to 4.5 hours, number to treat is 15. So better is to, guidelines now says you have to thrombolize within 1 hour or 45 minutes. You cannot wait or take decisions or just go on. If a patient is normal, there is a stroke, you thrombolize it. Just take a consent. So then, why is the delay? Here in Kargil, delay is because of again your peripheries are very far away. So patient time needed to stabilize the patient upon arrival. You do not require to do any investigation for thrombolysis. You have to just take consent to see whether patient is on any anticoagulation. If patient is not on anticoagulation, he does not have a gross major. Earlier we were saying there was a contraindication for. Now they are saying that relative, even there is a relative contraindication, you can thrombolize. I have thrombolized a 95-year-old lady. I have thrombolized 80. I have thrombolized very bad brains. Never, nothing happened. Yes, if I sometimes worry, there are multiple. I can give in giving 0.25, we give 2 milligrams per kg 10 active play. 0.2 yes milligram 10 से 12 तक देते हैं. So not giving 50. So then family related feature, time needed to BP control. Yes, BP is very important factor before thrombolysis. You have to keep BP between diastolic should be below 105. At least 105, systolic 180 and diastolic 105 is sufficient enough where you can thrombolize. Diastolic 110 and systolic 200, you have to decrease it by just 20 and systolic by 20 and diastolic by. That can be managed just with anti-G or something, whatever you require at that time. It's an emergency, you have to just decrease the BP. You cannot wait for infusion. You have to give 2-3 drugs, suddenly decrease the BP to 10-20 mmHg systolic and 5 to 10 mg diastolic and start thrombolysis. Problem with his family related problems are more common everywhere. Family does not know, they do not recognize the features. So we have to teach communities more than the doctors, because and then problem happens usually strokes present patients in the night. Again, that's the problem, we do not know. And then time is brain. Goal to treat IVTP is less than 60 minutes or 45 minutes. This is the stroke target worldwide. We have to thrombolize within 60 minutes upon the arrival to the hospital. So what is the act fast, as we are fighting against the time. So if a patient arrives at the stroke unit, you have to just less than 10 minutes you have to evaluate it's a stroke. You do not need any investigation. Yes, you can do a sugar test for thrombolysis. Yes, if you want to send, you can send. You check an NIHS. Less than 20 minutes CT scan should be done, and then it should be interpreted within 20 minutes, and you have to thrombolize within 45. We have thrombolized within 20 minutes in the stroke centers. So 60-year male, 2 hours of onset, he came with in the Sikkims. I was in Sikkims, NIHS was 18. We thrombolized the patient. Next day he was okay. Few days back, a patient was from Srinagar only. He went to Ujala hospital. At stroke onset was at about 12 in the day, 12:45. They reached to Ujala. There was only CT scan. There was not a neurologist. Neurosurgeon was there. So they wasted around 2 hours there. But luckily there was a good guy there. He told him, you go somewhere where there is available MRI and better to go to that. He did not refer the patient. He told him just you go to Medicare. Once patient reached to us in 3:45. Now 3 hours had been lost. 3:45, 4. Our MRI was busy. We took the patient out from the MRI, did an MRI. There was a stroke. It was not established stroke. There was subtle MCA territory in high, which is very difficult in other places. We did DWI imaging, usually 500,000. We did 4,000 DWI. It came in that. Angio we did. We shift. Once I thought, see it's the stroke, I gave him written drug. The time we completed the MRI with angio, he got the drug. We infused the tenecteplase 15 milligrams, kept 5 milligrams separately there in the emergency. Shifted patient, luckily cath lab was, they have closed the case, cardiology people had closed the patient. Shifted patient same time to the cath lab. Dr. Yaqub and I was there, did a puncture of 5F on thrombolysis. So there we do punctures of femoral punctures even after thrombolysis. There is no problem. Things are, we worry more than things do happen. So we did a puncture. Dr. Yaqub went to the this left side ICA, just took a run. ICA was occluded already, but we had given thrombolysis. 5 mg that tenecteplase we injected intraarterially. And within 5 minutes, everything was okay. I have a video on Facebook. Patient improved completely after 4 hours. And this artery got occluded. This was standing in the paras. There are multiple types of brain hemorrhages. We are not developed in the brain hemorrhages world as a whole. Things are now coming up. Endoscopic removal of hematoma. There are multiple trials. Still, things are not being accepted, but future will come definitely. Endoscopic removal of hematoma will definitely happen in next 4-5 years. In UK and US, people are doing it. In India, it's not yet accepted. Coilings, we are doing many things, coiling and endovascular treatment of brain hemorrhages. Then CVT, venous sinus, we have recently done, Dr. Yaqub will show you, sinuses we treat. Whatever disease of sinuses is there, venous sinuses we treat it. Then AVMs. So stroke for me, ischemic strokes are very common. That's why around 60, even if this is a very high altitude place, still ischemic strokes are more common here than hemorrhagic strokes. But problem is we do not pick them. Problem is CT scan does not pick them. So we say it is functional, kuch nahi hai. If you do repeated MRIs with these weaknesses, you will always pick them. So I will conclude because there is a lot of time and there we have 2 speakers more. If you have any question, you can tell me later. I think because we want to complete in this, that will be better. Thank you.
Thank you, sir. लगभग 15 साल बाद आपने हमें MBBS के फर्स्ट ईयर एनाटमी फिजियोलॉजी पैथोलॉजी सेकेंड ईयर का ऑप्थेल्मोलॉजी प्री फाइनल का और फाइनल ईयर का मेडिसिन सारा कुछ आपने 15 मिनट में पढ़ा दिया. थैंक यू सो मच सर. नाउ आवर नेक्स्ट स्पीकर इज डॉक्टर मोहम्मद याकूब सर.
So I will be brief about the cases of neurointervention we are doing in the hospital, Medicare hospital in Cox's Rise, Srinagar. So we are a team, Dr. Hilal, Dr. Basharat and me. So briefly I will be discussing a female who is a 45-year-old female who presented with sudden onset headache with transient loss of consciousness. She presented with the GCS of 15/15. There was no focal neurological deficit. So her investigation, which is most of routine investigation, is hemogram, her coglogram, and the electrolytes are normal. So this is CT. Why is it important? To understand is that there is bleed, and the nature of this bleed is subarachnoid hemorrhage. So the presence of subarachnoid hemorrhage is an emergency. It is in both medical and a surgical emergency. So diagnosing it is very important because the moment you know that there is a subarachnoid hemorrhage, which is non-paramesencephalic, it would mean that there is invariably the cause of this hemorrhage, if it is not trauma, is rupture of aneurysm. So in that setting, the evaluation becomes very important. So wherever you find the subarachnoid hemorrhage, it demands CT angiography or MR angiography, whichever you have available, because the cause in non-traumatic setting is is an aneurysmal rupture. So if there is trauma and still the hemorrhage is in the with basal cisternal predominance, still then that would mean that we need to evaluate this patient with CT angiography, because we don't know if it was the rupture of the aneurysm that led to the trauma, because when these patients develop aneurysm rupture, they present intracranial bleed, they can fall, they can have trauma. So then it becomes difficult to understand if it was the trauma that led to the bleed or it is the bleed which led to the trauma. So in that setting, it's very important to go for CT angiography to find the underlying aneurysm in these cases. So this patient was evaluated, and you see CT angiography, these are, we call them as VR images, volume rendered images. This is one of the reformatting technique. So you can see multiple blobs there. This is MCA, bifurcation aneurysm, ACOM located aneurysm, DACA aneurysm, and another side MCA aneurysm. So now we see that there are multiple aneurysms. Which one has ruptured? So you know that the bleed is on this right Sylvian location. So the most probable cause would be that this aneurysm is ruptured, because wherever the aneurysm is, the hemorrhage would be in that location only. Okay, sir. So now this is angiography. So we need to understand what is the anatomy which aneurysm has ruptured. So DS angiography. This is angiography. That's we take patient in the cath lab and do angiography in this patient. So now you can find that this is the left eye, right ICA aneurysm is located in MCA bifurcation aneurysm. This is another technique which is called 3D, which is this angiographic technique. We see the aneurysm with a small bleb here, and that means this is probably the ruptured aneurysm. So there are other aneurysms. The other side we see that there are three aneurysms. DACA, this is ACOM, this is MCA bifurcation aneurysm. So we took the patient for this aneurysm we put this stent. You can see that this metal kind of thing is here in. So we put a stent in this and simultaneously coiled the aneurysm. But you know that putting a stent would mean that you have to put patient on dual antiplatelet. So we didn't waste to put the patient at the risk of bleed because of dual antiplatelets. We coiled the other aneurysms as well. So in a single setting, all the aneurysms were coiled. Like you see, this is aneurysm with a stent. Then DACA aneurysm was coiled. Then ACOM aneurysm was coiled on this aneurysm, and then finally this procedure was completed by coiling the MC aneurysm as well. You see now that all the four aneurysms were coiled in a single setting. So this was very important for us as well as for the patient, because if we put patient on dual antiplatelets would keep the patient at the risk of rupture of other aneurysms, and treating all the aneurysms in the separate setting would mean this cost of 3 to 5 lakh in first sitting, so that would be too much cost. So in a single sitting we did it would only add to the cost of the coil. So in a single sitting all the aneurysms were secured and the patient was managed in the hospital. This was the final run. We see that the patient was stable, patient on dual antiplatelets, and patient is doing well. There is no focal neurological deficit. Patient is clinically intact. So this is another case, which is the 60-year female who is smoker, diagnosed as this unruptured PCOM aneurysm and a basal top aneurysm. But what was the problem in this case is that you can see that this is the MRI brain of this aneurysm. You see some abnormal vessels. This is AVM in this patient. So, but there are some abnormal things, that this is PCOM aneurysm, which is projecting into the interpeduncular cistern, causing the brainstem compression. Patient presented because of the brainstem compression in the form of ataxia, hemiparesis, Horner's, and other things because secondary to the compression of the brainstem. So another aneurysm was this one. This is a basal top aneurysm, which was also partially thrombosed. So now you see that these are aneurysms here, and this is the physiology, how the things happen clinically. So these are all the CT images you see. But what is important is to understand that these aneurysms there's an AVM is there, two aneurysms are there, how complex it is. Patient was already on on antiplatelets because he had been they put coronary stents for twice. So patient is now symptomatic. What we did is that the PCOM aneurysm, which was projecting, it's not only this aneurysm, there is other thrombus associated with it. So it was compressing the brainstem. So what we did is put a flood diverter here and partially coil this aneurysm, so that the compression, this sac will shrink down, so that the compression on the brainstem will decrease. So this is the flow diverter, a stent put inside the brain, and these are coils. So this patient is significantly, these are again the images of the same, how the procedure was done. Patient was on this dual antiplatelets and anticoagulation one, and then the other based on this treatment options. So patient significantly improved. Then now the patient, we are planning to do the basal trunk on this aneurysm in the second setting in this patient. So another case, this is the 50-year-old male who presented with right hemiparesis with the NIHS of 10. This is the same patient which was shifted to us from another hospital. So what we did is that we did MR brain, which was not showing something significant other than that this is high B value at 3000. We can see that there is subtle diffusion restriction in the insular and peninsular regions. But MR angio, you can do CT angio or MR angio, whatever is available to you. But on MR, we say that the MC is fine, but on the left side, MC is not, we are not able to see the MCA. So that this means there is a large vessel occlusion. So, and this occlusion of the basilar artery or ICA or MCA is, or a dominant vertebral artery is a large vessel occlusion, and in these cases we need to shift the patient to the cath lab. If patient comes with a good aspects and within 24 hours, we shift the patient to the cath lab. That is important. Large vessel occlusions cannot be kept as such. They are the demand and interventional following thrombolysis. You can bridge them with thrombolysis if within the window period. If not with the window period, that's after 4.5 hours. You need to shift them to the cath lab to bring this clot out. So these arteries become ICA, MCA, basilar artery, or the dominant vertebral arteries. They are very important. We cannot ignore these arteries because such are associated with a very morbidity and mortality if not treated. We took the patient on the angiography. You can see there is some clot sitting here, but with the thrombolysis we had given, there is some recanalization. We're seeing that the clot is now kind of floating with it. So we gave intra-arterial only in this case because we're knowing that the clot is now kind of floating. It is the surface contact is losing to it. So these are further runs. We see that the artery is completely recanalized. You can see that both the divisions are well open. So this is CT. He had subtle small infarcts in the insular region, but clinically the patient is improved significantly, and on discharge he had NIHSS of 0. So that this is how LVOs is managed. Large vessel occlusions are important. We need to understand them. So then this is another female who presented with this is important because in the setting that this was present with the diffuse SH, and she was importantly this diagnosed in the periphery as a case of blister aneurysm. Blister aneurysm meant that artery itself has ruptured. So these are very tough aneurysm in the sense that they can re-rupture. If you don't treat them immediately, they have high tendency to rupture within the 24 hours, and the rupture in these aneurysms is very bad because they don't have any wall. They can rupture too bad. So she was shifted to us. We did immediately angiography. You see, I will show you the angiographic images of her this. This is her aneurysm. This is small. You can see that artery is narrowed because of vasosource blood surrounding it. But this is a small bleb herein. It is this bleb which has ruptured. So these aneurysms have only one treatment. That is the flow diverter. We have to put stent to heal this artery. So we're doing the flow diverter in blood diversion in this case, and patient improved. But what was the problem is that the patient, these arteries, if we put them, if they bleed, then the in-hospital most important cause of morbidity and mortality in patients of SH in hospital is vasospasm. That is, the arteries start shrinking in the 4 to 14 days. This is a very important critical period in these patients. You have to keep the patient admitted in SH patient because they have vasospasm, and which causes the infarcts, diffuse infarcts in the brain. So this is the same patient, even after we put flow diverter, now she is developing the vasospasm. That becomes the management of this vasospasm becomes important. Hypertension is one thing that you do, and then the other thing is to give the intraarterial nimodipine and milrinone to dilate this. You have to go into the arteries and then give these drugs, nimodipine and milrinone, to open these arteries so that the perfusion to the brain is increased. So you see that how the size of the MCA has increased after giving the intraarterial milrinone and nimodipine in this case. And following she's at the time of discharge. She's doing good. There is such no significant focal neurological deficit in this patient. So now, this is another important thing. This is an elderly female who presented with this epilepsy partialis continua because she was admitted in one of the tertiary care hospital in the Kashmir, but somehow she was shifted to us. Now we see that she has chronic subdural hemorrhage, and on the underlying brain is thickened, gyri are thickened, and there is diffuse white matter edema. We did EEG that she has continuous, she has epileptiform discharge in this hemisphere. And what we did, she was on anticoagulation because she had underlying atrial fibrillation, and she was on anticoagulation. So, if a patient who has chronic SDH and is not symptomatic because of the SDH, not that by that we mean not significant midline shift, and is on anticoagulation or has recurrent chronic SDH, such patients are important indication for doing them this middle meningeal artery embolization. What we do is that this is middle meningeal artery. We go into the middle meningeal artery. This is its frontal trunk and the parietal trunk. We go into the parietal trunk and then into the parietal trunk. Deposit the PVA particles. We just give PVA particles in this artery so that the the important is to note that these chronic subdural hemorrhages, the pathogenesis is that they develop neovascular membranes, that it is the recurrent hemorrhages in these, like it is a kind of endometriosis, like in endometriosis continuous recurrent bleeds happen, same happen herein. So what we do is that we put particles in these arteries and then embolize this bed, vascular bed, so that it will shrink. But you can see now we are going, this is the arteries and we embolize, and now then we are going in this parietal trunk and we embolize it as well. So you see now the trunk has almost been embolized. And this is, you can see that in a short duration of say 3 weeks, this subdural hemorrhage is almost near completely resolved. So almost the protocol is to find in the 3 months time, we see that most of the chronic subdural do resolve, but it's in a short duration of time to our surprise that she has almost near complete resolution of the chronic subdural hemorrhage. So this is another case, one to understand that this is MCA bifurcation aneurysm. You can see herein, we planned this patient, this was a non-ruptured aneurysm, we planned it for the flow diversion, and in this case there was one complication. What we meant is that there happened a rupture during the procedure, so that brain is bleeding now. So we put balloon and then sealed the artery so that the artery perforator which has ruptured will heal up, and in the course of time we see that the artery is now, the bleeder is now stopping, and she had fortunately tore this surprise. She had a good in hospital course, and she was discharged with the subtle weakness in the hand. Now she is improved completely. So this another female who is present with the sudden onset severe headache, we can see that there is a bleed in the ACOM location. So this is by definite that there must be an aneurysm located here in which must have ruptured. But what we did is that we did angiography, but we could find nothing. This in first angiography, this is the second angiography, because we can see that A2s are separated, so that means there is hematoma. So we took two bilateral runs in on one of the cath labs and find that there is a small blister located herein. So we placed the patient, took patient for flow diversion and put the flow diverter across this. You can see that we are placing a stent from control to the ipsilateral A2, A1 ACA. So this is her the stent. You can see here in how the aneurysm has been here on this sealed up, converted by the stent completely, and then these are the procedure of the same. So a patient had subtle middle frontal hypodensity. Other than that, you can see the stent is well in place, and everything brain is looking normal. And she was discharged completely with no focal neurological deficit. So now the another thing which are now venous interventions. Venous interventions are now going to be one of the important interventions of the brain. You can see this is the patient who present with this headache, persistent headache with this papilledema, grade 4 papilledema. She was put on the topiramate and the estrozolamide, but for 1 year she was not responding to them, and her headache was persistent and her papilledema continuing. So this is angiography. You can see that the transverse sigmoid transverse ejection or stenosis here in this side and this side as well. So now what do we do is that we measure the pressure gradient. If how significant the stenosis is, this is microcatheter we're taking in the superior sagittal sinus, and we measure the gradient from this transverse sinus to the sigmoid sinus and see how gradient of pressure there is. If the pressure of gradient is greater than 8 mmHg, which means that the gradient is significant, and such stenosis would respond to the stenting, intravenous stenting. That's we put stent across this stenosis. So now in these images you can see that how we are taking these microcatheters and microwires across the stenosis to measure the pressure gradient. And in this patient there was severe pressure gradient of 15 mmHg from the right transverse to the right sigmoid sinus. So we did venography from the venous side as well. You can see that there is severe stenosis in this side, and other side as well. This bright areas, you can see these are arachnoid granulations which are responsible for causing the intracranial venous stenosis in this location. So what we did is put a stent across the stenosis and then measure the pressure gradient. Now we are measuring the pressure gradients. There was significant drop in the pressure gradients after pushing the venous stent in this patient. That's the pressure dropped to less than 2 mmHg gradient in these patients. So the patient is doing well, and her this vision has stabilized. So with this, I conclude all the cases we have done, which are the major representative cases of the brain hemorrhages, intracranial hypertension in the form of vision retention, or in the tinnitus. The same indication is in the tinnitus, which is not responding, or which is a kind of pulsatile or venous tinnitus. Venous stenting is indicated in those cases. Thank you.
First venous stenting.
Yeah, this is the first venous stenting which has been done in this. Same way, middle meningeal artery embolization. For that, we are thankful to the Bashar sir for giving this.
Also the first case.
Yeah, that's the first case of middle meningeal artery embolization done in the yeah. Yeah, just missed it only. So it's not in India. So there are doing this outside this Kashmir people are doing it like right and left. For us, it was the first in the Kashmir. Thank you. Thanks so much.
Neurological examination, clinical history. MRI is the investigation of choice, and CT is optional to look for any parts defect if there is, or any listhesis. Then we have to exclude other causes of back pain. Sometimes facets can give similar pain, sometimes piriformis syndrome can give similar pain, sometimes there are other causes like discitis and other things. So surgical techniques, anesthesia we usually prefer nowadays spinal anesthesia. If we have to do 2-3 levels, sometimes patients is not cooperative, we can go for general anesthesia. Sometimes patients are not fit for even spinal anesthesia. I have done under local anesthesia also. So most of the times we give a midline incision if you have to go both sides. But if we have to go one side, we can give paramedian incision. And operative microscope we use, we can do a laminotomy or hemilaminotomy, depends. And these are the things you need. Usual time is around 45 to 60 minutes in a single level disc. Hospital stay usually is 1 day at our place, and usually patients return to work within 2-3 weeks, sometimes up to 1 month. Well, success rates throughout world, it is around 90%. They usually improve function and quality of life, and they have a rapid symptom relief. Well, definitely there are some complications, but in experienced hands, it's not much. Dural tear, it's very rare. Nerve root injury, usually we do under high illumination, so it does not happen. Well, recurrent herniation is one part which can happen. It's reported 5 to 10%, but I will say I have done almost 5,000 surgeries by now, and recurrent is around less than 2 to 3%. When infection hematomas can happen in any surgery. I just want to show you some. This is a patient from Ladakh only. He's from Leh. He's first cousin brother of one of the gastroenterologists, Yasin Muju. So he actually came same day from Leh to Srinagar by air. He was having an extruded disc. This is an intraoperative of the same patient. This is how it looks under microscope. You are removing this herniated disc, and the root gets. Now the root is pulsating nicely. This is the immediate post-op video. Next day, how you can see how patients improve. This is at the Medicare hospital. It is 2022 video. So they get a dramatic relief. This is his reviews. I don't want to. I will skip it.
परवेज अहमद, आप कहाँ से आए हैं? लेह से। आप क्या काम करते हैं? बिजनेस। तो कब से आपको कमर की तकलीफ थी? अच्छा ठीक।
अच्छा ठीक। So this was his MRI. Just a minute. This is one patient who traveled all the way from Canada. Most of the people you might have seen this. He traveled all the way from Canada to get operated under me. Although I have seen him when he came first as a tourist. I told him that he needs a spinal fusion. Then he went back to Canada. Then he went to Europe. He explored many places. Then he came back to me to get operated. It was his review after that. And This is the today's case we have done today with Dr. Ahmed Ali. She was a 60-year-old female with a severe back pain with radiation. This was his MRI. Here you can see a herniated disc compressing the right side. This is the sagittal MRI. Here is the herniation. Just a minute. This is today's case at the hospital. See, this is the incision, and through this incision we are doing it. It's almost less than 2 centimeter incision, and we completed this case through this only. And we were watching on this 4K, this monitor also. This is Dr. Ahmed Ali assisting me. This was the final, when we closed the incision. This is my thumb on this. So you can see the incision is just less than 2 centimeter, 1.5 centimeter. So these things can be done here also. This is another video of the same patient while I was operating. This is the final photo with the operating theatre people. Thanks for giving me the opportunity to do this case, and I hope we will continue to support you from Srinagar. Whenever you people need our expertise, we are just one phone call away from you. We are a team of actually 5 doctors. We are 3 doctors here. We have one more neurosurgeon, Dr. Azhar, and we have one neuroanesthetist, dedicated neuroanesthetist, who is always with us. And we hope to give a proper neuro care to the people of Valley, as well as to the people of everyone, Ladakh, whoever comes. Thanks everybody.
Sincere gratitude, sir. Thank you so much for your contribution to our people. Last but not the least, I would like to request Dr. Oli Dynamic Field Director.
Kargil, doctors of district Kargil and general public of Kargil, I would like to express my sincere gratitude and thanks to the team of doctors from HIBA Neurosciences who have taken time out of their busy schedules to visit here to serve our poor patients. And believe me, they are very, very busy. It was very difficult for them to take time out of their busy schedule. If you go to Srinagar to get appointment from them, it takes months to take appointments. So it's our patients have been very, very lucky that the doctors have arrived at our doorstep, and they have provided service to our patients. They have consulted around 400 patients and conducted surgeries, 4 microdiscectomy surgeries. In spite of doing all this, and they were dead tired, still they came here for this CME, and it's very commendable. And it reflects their dedications to not only patient care but also for continuing medical education and passing on the knowledge. So it's because when we see patients in OPDs, when the patients get over 50 patients, we see more than 50 patients, we see aaj to bahut dekh liya. So we can see how much they were tired, seeing more than 400 patients in 2 days and conducting 2 surgeries also. So it was very, very commendable job they have done. And also I'd like to thank all the doctors that have gathered here to participate in this CME, especially Deputy CMO ma'am, Medical Superintendent sir, consultants from District Hospital Kargil, consultants from the field, block medical officers from District Hospital Kargil and field. I would like to thank all of you for being here, and also I would like to thank my team of Bakaria who have put a lot of efforts to make this a success, and also the team media personnel also for giving coverage for our program. Thank you very much.
Thank you, Oli sir. Now, I would request you all to proceed for dinner. Time. Yeah, if anybody else, I don't think anybody wants to ask questions because everybody seems hungry. If in case anybody wants to ask any question, you are welcome, please. Yeah.
If a patient comes with suspected ischemic stroke and CT is normal, should we go for CT in every case, sir? CT to rule out any large vessel. Yes, recommendation is CT with CT angio. So that if there is a large vessel stroke, then we can refer them for thrombectomy. Suppose if there is a large vessel, or if you have to thrombolize here, it is better to do CT angio in each case. Yeah, it is. What people do, they first thrombolize and then go for it. It takes two. You do CT with CT angio. It should be a protocol. Just like ours, we had made a protocol of CT stroke protocol or MRI stroke protocol. So clear, we do not do just CT or MRI. We do stroke protocol clear right from neck to brain. That will guide you clearly if there is an occlusion in an artery. Even if CT is normal, you will be knowing that there is an infarct. There is already, it has not established arteries occluded.
For some this incidentally detecting aneurysms.
Yes.
Last time with the headache, severe headache, we did an NCCT that showed a hypertension area in the ecom area. Then later on CT angio was done showing ecom aneurysm. So they also need to get coiling each case. Huh?
No, each case does not require. Suppose a patient comes with a headache. If it is ruptured aneurysms, always need treatment because they will re-rupture. So re-rupture chances of rupture is very high. Usually within 1 week they rupture. But if patient is unruptured, so you again have to do CT angio to see what is the morphology of an aneurysm. It does it fall in a high risk case or low risk case. Suppose a clear rounded aneurysm of 5 mm is not a high risk for a rupture. Yes, if you will decrease the blood pressure and other things, there are less chances. But aneurysm itself is a very, ruptured aneurysm is a very difficult. That is why people do not want this aneurysm to get ruptured. They want to get it treated. And endovascular treatment for any unruptured aneurysm, it is recommended. We do it routinely. But it is an elective case. We can manage it. It is not an emergency for us. That is what I was telling. A ruptured SAH is an emergency where you do not want to waste any second.
Thank you so much.
Thank you.
Yeah, for stroke, angio is must. You cannot diagnose an LVO without patient is okay, NIHS of 2-3, but there can be an underlying LVO. So like I said, you showed that there are this. So it is this recommended is that if you suspect a stroke, you do NCCT. If you have CT, then do CT angio, but including head and neck. Yeah, so that's important. Stroke is not diagnosed unless you do NCCT as well as CT angio, head and neck. Yeah, there is, but then roll up perfusion say after 6 hours, but that there is limited roll up in current studies, limited roll up perfusion. But NCCT angio, NCCT head and CT angio head and neck would suffice a case of stroke, and ischemic stroke should go under these things. And same way, atypical brain hemorrhage should also go CT angio brain in the same setting. You see atypical hemorrhage in the brain, say you see occipital hemorrhage or frontal lobe hemorrhage, which is non-classical for this hypertensive hemorrhage. Do CT angio there only. CT angio brain is indicated in these patients. Yeah, because MCA bifurcation aneurysm, they can present as this perisylvan brain hematoma. Same way, these supraclavicular diastases, they can sometimes present as frontal lobe hematomas. AVMs are important because of this. AVMs, they can present as hematoma only without anything other. So, stroke, if it is hemorrhage or ischemic, angio brain is must.
Thank you, sir.
Which increase our time. In some patients, after 6 hours, we have to do perfusion imaging or diffusion flare mismatch. What we do in MRI, if a patient is up to 6 hours, you do not need to do any imaging. I was recently in a conference in stroke. These guidelines predominantly came from a doctor. He's an Indian working in Calgary. Now he was telling, earlier they were telling do a MRI perfusion with MRI to see there is mismatch. After giving all the guidelines, he was saying up to 24 hours, you open any artery, there will be definitely benefit. Mortality benefit is there, morbidity benefit is there. So a person who had wrote these guidelines for last 20 years, he was writing these. His name is, I am not forgetting his name. He's a radiologist. So last year conference, he told that leave this business of this perfusion and other things. If artery is occluded, large artery, up to 24 hours, you open an artery. We have seen many patients. After we have even discussed, we were going conference all over the India and other places. People have done thrombectomy in day 3, day 4, or day 48 hours after that. So how do we do it? If there is still a perfusion-diffusion mismatch, or there is a diffusion-filial mismatch, then that patient clearly gets an indication of doing thrombectomy. Even patient is after 24 hours or after 48 hours. I have seen a case, a person has shown a case after 5 days of thrombectomy.
Thank you, sir.
So take home here. CT angio shows large vessel occlusion, and if it is within the 4.5 hour, you thrombolize it and then simultaneously shift to the patient, because for large vessel occlusions, there is a golden standard is a bridge therapy. That's you thrombolize if it is within 4.5 hours, but simultaneously send to the center where mechanical thrombectomy is done. So if it is after 4.5 hour, there is a large vessel occlusion, it's better to shift to the patient immediately, because within 24 hours, if we say that if we find there is on NCCT, we find there is some area of brain which is preserved, let's say greater than 3 areas, for up to 24 hours, we will open these patients, because they have significant benefits when we open these patients within 24 hours. So it becomes important to understand that within the 4.5 hour, you thrombolize and shift to the center where mechanical thrombectomy is done. If it is after 4.5 hour, you just confirm the diagnosis and send to the center where this thrombectomy will be done.
Thank you. Sir,
EEG machine. Is it possible weekly basis पे यहाँ पर EEG करा के आपको रिपोर्टिंग के लिए भेज दें?
Yes.
आपको डेट हो मतलब फिक्स जिस पे आप टाइम
Sir, we were discussing the things. You can send a person. We will train him first for doing an EEGs. Okay. We will train. Reporting के लिए if a technician can send us anytime that EEG, if first we will train him, we'll go do reporting on the same day. ऐसा कुछ नहीं है. We will send you on WhatsApp reporting. We can do on WhatsApp reporting. It takes us 2 to 3 minutes. First we will train your person. Suppose I have an EEG technician, I have trained him. Then it takes, once he is trained, it takes us 1 minute to just report. So because still we have to report you on WhatsApp. We cannot report you on this. But if you want me to report, I do not have a problem. I will report you properly. But benefit for the patient's benefit. Suppose I went there yesterday. There was it was very nicely managed. There was a child who had a neonatal status. So they have given. I was telling they have given first phenobarbital, then levetiracetam, then phenytoin. 2 days old child with a proper dose. First drug, it did not help them to stop the epilepsy. Then they were themselves very childish, drowsy. But once I went there, child was okay. We did an EEG. There was some subtle epileptiform discharges, which was okay for a child. So he has been already very nicely managed. So our help was, there was epilepsy, that status had stopped, and patient, most probably they will discharge the patient on day or two after 2 days. So everything you have here, you are competent doctors here. Only thing, there are some misconnections. We can help you anywhere. We can help you, sir.
Do you prefer any one of them?
So our
efficacy same in all the...
Yes, our preferences do not matter. Whatever are the recommendations. Earlier, Altiplase was the only recommended drug. Previously, up to 2000, just 3 years back, people were using tenecteplase. Now, after trials, they have shown that tenecteplase is equally better than Altiplase. Good thing with Altiplase is the cost-effective drug, it costs around 20,000. Second, you give it in bolus in 2 to 3 minutes. 10 hectoliters, not LTPLS. LTPLS you have to give up to 60 minutes. So we were using first give bolus of 10 minutes and then so we are ourselves preferring 10 hectoliters. 10 hectoliters we are preferring.
But there is no difference in efficacy.
There is no difference in
experience.
efficacy. No.
Once I used the tenecteplase place and I got a call from Skims. This is not recommended.
No. So you have done one good thing. A patient I have seen here they have thrombolysis with reticulase. Then again Skims, I was in Skims, we were discussing is it recommended. There were multiple papers in China and other places with reticulase thrombolysis, and now people are adding reticulase this in the drug. So whatever is available except streptokinase. Streptokinase, people have shown that there are much more side effects than benefits. So newer drugs have benefits.
We have done one with reticulase.
That is what I am saying. I was in Skims.
Luckily it was effective, but patient was...
It was effective.
In casualty within 1 hour.
Yeah. Improvement is suddenly with thrombolysis. Deficit occurs fast. It occludes an MCA territory and there are no collaterals. And there is a lot of deficit, and the more we early this do thrombolize, benefits are much. In elderly patient, where we are seeing there is penumbrized weight, because there are collaterals already developed. There is atherosclerosis, they already have multiple collaterals. Once artery gets occluded, there are other ways to remain it open that supply the brain. That is why in elderly, usually in atherosclerotic, or there is a small stroke, NIHS of 4, but their carotid is very narrow, 99%, and other side it is flowing. So that gives you time for 24 hours, 48 hours to treat the patient, that occlusions. So this is actual understanding in young people or in children. We are facing problems in pediatric age group. I have seen today a baby of around 6 months who had a large MCA stroke. They have went to Chandigarh and every place. Whole brain is totally destroyed. We did CT today, MRI was in there. And unfortunately, this pediatric age group strokes are usually missed. There is some pediatrician, there is a disease like in pediatric age group where people have these giant AVMs and other things. Even in neonatal age group, they can be easily treated. Even in 2 days or 3 days child. Vein of Galen malformation, other things. But we are very unfortunate. A person from Germany who has started this name was Lars Junius, his father of intervention, neuroradiology and intervention, everything. They were doing in Germany in 1970s, this vein of Galen malformation, thrombolysis, coiling and other things. So whatever development they had in 1970s, even Kargil is better what Germany would have been in 1970s, because there were no other things. There were no MRIs, there were no these machines. They would have a flora and they will embolize on it. So it was only the will. And then they have embolized many vein of Galen malformations. Unfortunate thing in our setup is in Kashmir, we have never seen any vein of Galen malformation even referred or even treated. That is an issue.